Good evening. Welcome to the EUROGEN webinar programme. Just before we get started, I'd like to take a couple of minutes to explain a little bit about what a European Reference Network is and does. EUROGEN is one of 24 European reference networks created by the European Commission in 2017. And they're all networks of highly specialised hospitals collaborating to help patients with rare diseases and complex conditions. And we deal with rare urorectogenital diseases and complex conditions that all need highly specialised surgery, so where the expertise is rare. So some of our activities, we do virtual consultations using secure IT platform, which enables us to conduct European level MDT discussions on particularly tricky cases. We also have training and education activities like this webinar programme. We write clinical guidelines together, and we've also produced this fantastic book on rare and complex urology. We also have a patient registry, which is very exciting, as our members, which are 56 hospitals in 20 member states, all start to contribute data. We hope to have a really exciting resource over time where we can track improvements in care for patients and also quality of life issues. So this evening, the topic is multidisciplinary management of cystinuria, and it's a great honour to welcome two very dedicated colleagues, Dr. Kay Thomas and Dr. Matthew Bultitude, and they're both consultant urological surgeons working in Guy's and St Thomas's Hospital in London, UK. And they're both clinical leads for the specialist Cystinuria service at Guy's and St Thomas's Hospital. So the webinar is going to be a state-of-the-art presentation on the latest evidence for medical and surgical management of cystinuria, including optimising medical treatment, choosing surgical options, dietary prevention and patient engagement. The webinar is eligible for ERKNet accreditation points for those live attendees who fill in the post-webinar survey. And the webinar is kindly supported by the ESPU and the ERN also for rare kidney diseases. Many ERNs work in close collaboration with each other. So I hope you enjoy the webinar, and please feel free to type in your questions. We'd be very happy to discuss them with you at the end. Thank you.
Thank you, and welcome to this webinar on the multidisciplinary management of cystinuria. My name's Kay Thomas, and I'm joined by my colleague Matthew Bultitude. We're both consultant urological surgeons at Guy's and St Thomas's, and we run a large cystinuria practice in the UK, so we're just going to tell you a little bit about our approach. We don't have any conflicts of interest. So the first cystine stone was described over 200 years ago, and it was described by William Wollaston. He called it cystic oxide, which is not quite correct, we now know, but he did get two aspects of the disease correct, in that he said it was probably very rare, and he also described quite nicely the homogeneous appearance of the stone, as you can see in this quote here. This is a pictorial representation of that first stone, as described in Marsette's essay, and then on the right you can see a photograph of the actual stone, which is held in the Gordon Museum at Guy's Hospital. The blue coloration is because it's been exposed to the light, and is something that we do see with cystine stones if they're left in the light for a long time. So how rare is cystinuria? Well, this is a difficult question to answer, and something that within eUROGEN and ERKNet, which is our sister network on the nephrology side, is something that we're trying to address through registries held within the European Reference Network. As you can see, there's quite a difference in different countries, but the reality is we're still not quite sure of the true incidence. There's equal incidence in men and women, and as I said, a difference across different countries. So it's important to suspect and investigate for cystinuria, but obviously not for testing in everybody because it's a rare disease. So the majority of stone patients won't have this. So who do we test for, and what are the features that we want to look for? So as you can see, a young age at first presentation. This is a graph from our cohort of patients showing that the peak age that they present is between 11 and 20. Patients with frequent recurrence, frequent stone passage, bilateral disease, if they have a family history in the siblings of stones, which will come onto the genetics of why it's important that the stone disease is within siblings. If they've had an early nephrectomy for stone disease, if you can't see stones on a KUB X-ray, and if the Hounsfield units are around 800 on CT, all of these may prompt you to think about whether this is cystinuria. So what is cystinuria? It's a failure of the reabsorption of 4 amino acids, cysteine, ornithine, arginine, and lysine, through a transporter within the intestine and the proximal tubule of the kidney. These transporters, or rather the transporter, has 2 subunits, and each of those subunits is coded for by a different gene. When the transporter is faulty, we get increased levels of cysteine in the urine because it's not reabsorbed through this transport mechanism. This is the biochemical structure of cysteine, and it's actually 2 molecules of cysteine, which are held together by a disulfide bond. And it's the cleaving of this bond when you use a laser that gives the distinctive smell in theatres of breaking up a cysteine stone. The reason that we only talk about cystinuria and we don't particularly worry about the other 3 amino acids that use the same transporter is because cysteine is not soluble at the levels that are found in the urine, whereas the other 3 are soluble, so they're not clinically relevant. The classification of cystinuria used to be biochemical and was based on the parent or the child's urinary cysteine levels, as you can see here. This is largely historical now. We don't use this classification anymore. And that's because we now know the genes that are responsible. So SLC3A1 is on chromosome 2 and codes for one of the subunits, and SLC7A9 is on chromosome 19 and encodes for the other transporter subunit. And the classification is dependent on which mutation you have in which gene. So the inheritance pattern of cystinuria is quite interesting. For many years, it was described as autosomal recessive. As you can see here with SLC3A1, that is still the case. So you need 2 faulty genes in order to inherit the disease. But with SLC7A9, as we've come to understand the genetics better, we realize that you can be both inherit this in an autosomal recessive fashion, or some patients are carriers but manifest the disease. And this is called autosomal dominant with incomplete penetrance. This was quite a controversial idea over the years, and we've done some studies in this describing whether we feel that cystinuria is always autosomal recessive. And I think this newer way of looking at SLC7A9 is now largely accepted. We've also published on the genetic diversity of our patients within the UK. This is very early work from our clinic when we had just over 70 patients who were genotyped. And as you can see, we found many new mutations. The most common type of mutation is a missense mutation in both of the genes. And then it's interesting to us, we have quite a few families that come to the clinic, that the siblings don't manifest the disease in the same way. So despite having exactly the same mutation, they don't present with the same phenotype, even including one identical twin pair that we have. So clearly there's something more than just the gene at play. It may be that their epigenetics and different genetic features that mean that these patients don't have the same phenotype despite having the same mutation. So what has been the progress with genetics? Well, we know that genetics of cystinuria is well described and understood. And actually, although it's a rare disease, it's better understood than many of the other stone diseases. It's clinically and genetically diverse disease, as I've shown you, and the mutations do vary according to geography. So different countries, people's different ethnic backgrounds means that they will have different mutations. Excitingly, in terms of therapies, we do have mouse models because we understand the genetics. Then there are now knockout mouse models that can be used to test new therapies. But what we still need to know and don't really completely understand is what is the impact of an individual mutation, and therefore how can we offer targeted therapy? We also would love to know how to predict the prognosis of the disease and the response to medication based on genotype. I'm just going to hand over to my colleague, Matt Bultitude, to just talk you through the diagnosis and the approach that we take in the clinic.
Right, hello everyone. So looking at diagnosis, this can be either with stone analysis showing cysteine stone, observation of cysteine crystals in the urine, or the finding of abnormal excretion of cysteine, so measuring cysteine levels in the urine. The genetics which Kay has just described is not formally needed for diagnosis and is not therefore recommended in the guidelines, but it is occasionally useful for diagnosis and genetic counselling. One of the problems is, as Kay just discussed, there is no major genotype-phenotype correlation that's ever been identified, which would then help us stratify either follow-up or treatment based on the genotype. What do we do in clinic? Well, I'll talk about our structure in a minute. Obviously, we assess for any stone episodes over the last few months, and some patients get recurrent episodes of pain and may pass small stones without knowing it. Others, of course, may have had stones and stone intervention. In the clinic, we obviously measure blood pressure and renal function, and we check a urine dipstick for both for hematuria and proteinuria, which is important. We measure the urine pH in clinic, but we actually ask most of our patients to bring a pH diary with them that they've kept at some point in the last few weeks, just to see what their urine pH is doing on a day-to-day basis. And we also measure urinary levels of cysteine and look for crystal urea. In clinic, every patient gets an ultrasound, so we use this first line and use CT only when it's actually needed for confirmation or planning for surgery. So what measurements can be done in the urine for cysteine? So we can do a spot urinary cysteine 24-hour levels, of course, and measure crystal urea, and those are the three that we would have access to in our clinic. There are ways of measuring supersaturation, and there is a proprietary test in America called cysteine capacity, which tries to get away from the problem that often cysteine levels are low because the cysteine has crystallized out into stones, and this tries to measure the capacity of the urine in terms of absorbing more cysteine. That's certainly not available in the UK, and I don't think it's available anywhere in Europe. And you can also measure drug cysteine complex levels to try and look at compliance and also the amount of drug levels that are achieved. But there are problems, of course, with availability, as I've just discussed. When do you collect it? Is early morning good? Is 24-hour urine better? How do they do it? How do they bring it to clinic? Is it representative? And the problems I've just outlined with cysteine being in a solid form. And this sort of fits with the guidelines, which I'm going to quote throughout some of these slides. Which was published in Kidney International in 2021, which says that crystal urea can be useful if you have that available in your centre, and describes measuring urinary cysteine, but the limited value due to the problems with interpreting that. So often it is more important to go on clinical episodes. We set up a dedicated Cystinuria clinic in 2008, and we've now had nearly 300 referrals into our service from all around the UK and a few from abroad. The clinic is set up so you have a joint urology and nephrology consultation at the same appointment, and we also have a dedicated uroradiologist to perform an ultrasound scan for all patients, and all patients are given the opportunity to be seen by the dietitian in clinic. So it is really a one-stop shop for them to come and get these appointments and things done. Behind this, we then have specialist pharmacy to support to try and help with the medications, a dedicated stone nurse support, and we set up, as we'll describe later, a patient information website for our patients. And then in clinic, we're able to offer genetic testing, which I think is now more widely available to centres. The pH diary, which I've discussed, measuring amino acids, looking at urinary crystals. We recruit everyone into a UK database as well, called the Rare Renal database. We give everyone a card to put in their wallet, which I'll show you in a second. And we try to offer surgery if it's needed really promptly, because that's what these patients often need. So often care can be fragmented, so we do give them these different points of access with the nurse, the pharmacist, a dedicated email that they can contact us on if they're having trouble and can't get through any other emergency services, and the ability to walk into our services. And this is the patient card, which actually patients have found very helpful to put in their wallet. And this is if they attend an emergency department, because often these patients are accused of malingering, maybe drug seeking, and this just tries to give them some authenticity to say that they have cystinuria, because often the doctor seeing them won't know what it is, suggesting they might want to use ultrasound rather than CT unless CT is absolutely needed, and that they may require opioid analgesia. Frequency of follow-up, we just followed the guidelines, which would suggest that which will be any time between 3 months and annually, depending on the disease activity. And of course, we're looking for measuring blood pressure, proteinuria, and the medication monitoring, as well as looking for new stone formation. If patients do need a CT scan, and often they do, either for the emergency episode or for planning of surgery, then one thing that we thought would be quite interesting to show is the relevance of Hounsfield units. Often cysteine stones are thought to be quite hard stones, and people often use Hounsfield units as a measure of hardness of the stone to try and guide treatment. But actually, when we looked at a large cohort of our patients and looked at their CT scans, as you can see from this graph, almost all the patients have Hounsfield units under 800, which would often be thought of being maybe a softer stone. So this is clearly not helpful in cystinuria patients. And it may well be that those 4 outliers on the graph actually had some element of calcium phosphate within their stone. And it can be useful clinically too. This is a patient that we operated on who had so there had this stone, which had a mini PCNL. The Hounsfield units of this part of the stone is 700s, which would fit with cysteine, and that's certainly what that stone looked like here, and that's the appearance of that stone. But then when we were doing it, we came across a very different type of stone, a very clear demarcation between the 2 types, and that top cap here has a Hounsfield units of 1200. And so this was a mainly cysteine stone with a calcium phosphate cap on top of it, and this could have been predicted by looking at the Hounsfield units on the CT scan. In terms of medical management, we obviously aim to reduce their urinary cysteine levels to prevent stone formation. And we can assess this by the urinary testing or by clinical episodes. The cornerstone of treatment is through diet and fluid management, and then alkalization of the urine. And we reserve the chelating agents, tiopronin or D-penicillamine, for those patients that really need it. Looking at the dietary advice, all patients should follow a low salt diet because increased sodium excretion in the kidney leads to increased cysteine excretion, as you can see from this old graph down on the bottom right here. So patients should be advised to follow a very low salt diet when possible. Animal protein is rich in methionine, and this gets metabolized to cysteine and excreted in the kidney. So we know that diets rich in animal protein will lead to higher levels of cysteine in the urine. So patients should try and moderate their animal protein intake and replace this with vegetable protein, because of course it is important to have enough protein in your diet. It is important to mention at this point that we don't advise limitation in children because it's essential for growth. And in the box on the top right, we've just put some of the figures when we audited our data, just to show the improvements that patients have made with having dedicated dietetic support available to them at clinic visits, showing significant increase in fluid and fruit and vegetable intake and reduction in salt and animal protein. In terms of fluid, I think we probably all know they need to drink a lot of water, and so at least a minimum of 3 litres a day. Some patients achieve this easily and drink 5, 6, 7, 8 litres even. Some patients do struggle to make even the 3 litre limit. Rarely patients may set an alarm to wake at night to drink and then void, but very few of our patients now do that. And some patients can measure their specific gravity just to sort of assess their levels of hydration of their urine. In terms of medication, we preferentially give potassium citrate and spare sodium bicarbonate only if potassium citrate is contraindicated or cannot be tolerated, and this should be taken at intervals throughout the day, and patients should measure their urine pH and try to aim for a target pH of 7.5 to 8. And the graph shows why this is so important, because of that exponential rise in solubility of cysteine when you reach these levels of up to around 7.5 and 8 here. But it is important not to go too far because of the risk of precipitation of calcium phosphate if the urine pH goes too high. And this just shows some of the ways that patients measure and report their pH. Often patients have dipsticks at home. David Goldfarb in New York gives litmus paper to all his patients. And we've increasingly been getting patients to buy a cheap pH meter and use this as an easy and reliable way. And some of our research looked at that and showed it was probably more accurate than using dipsticks at the levels that we want it to be. Patients fill in a chart, often like this, but sometimes on a scrap of paper, and that, of course, is fine, because what we just want to see is a trend, and are they reaching those levels of 7 to 8? And then there's this patient who was very dedicated, and for about 3 months, he recorded every single urine and measured the pH, as you can see, and he marked in red there where it was dipping below what he thought it should be. He plotted this graphically and was able to work out in his diet what was influencing it, and so he made significant changes. Here's an interesting story, because he presented in his 30s with a staghorn stone, which you can see here, which he had treated with a PCNL. He then modified his fluid intake, modified his diet, and he has not now at 10 years of follow-up had any stone recurrence without any other medical management at all. So it just shows what can be achieved if you can be committed and dedicated and able to make those changes. In terms of chelating agents, I obviously mentioned tiopronin and penicillamine, and they cleave the cysteine molecule into cysteine, which is 50 times more soluble than cysteine, so it is then excreted in the urine. They do both come with a similar range of side effects, which we've listed on the slide here, and they can be difficult to tolerate. And it is important that they have regular monitoring, both of blood tests and urine for proteinuria, as shown here. And it would be important just to check the manufacturer's recommendations for that. Typical doses for both range start usually around 750 milligrams to 1,000 milligrams a day in divided doses, and can be increased as needed after that. Some of the challenges, well, the drugs definitely do work, and we've shown that in our data in terms of reduced stone episodes and intervention if you can take and remain compliant with the medication. But they do come with a significant side effect profile, and this is data from a large French series, which showed that nearly a third of patients had at least one side effect while taking it. What we have shown in some of our research is that if you can't tolerate one, it is worth trying the other one, and 50% of patients will be able to switch over to the other one. And that can go both ways, so tiopronin to penicillamine and vice versa. However, there are issues with funding. There's been significant price gouging of tiopronin around the world, so that's become very expensive, and some providers have stopped giving tiopronin because of this. And there have been various shortages of supply for both medications at different times. Patients are known to be at higher risk of CKD and early onset hypertension, and this is figures from us that showed 75% of our patients have abnormal renal function as measured by eGFR, and half of them have hypertension, and relatively similar figures from that large multi-center French study as well. So now just moving on to talk about some of the surgery, and this slide just encapsulates some of the problems that our patients face. So the picture on the left is the back of one of our patients. As you can see, she has had bilateral open surgery here as a child, although thankfully now open surgery is vanishingly rare. She is actually well maintained on tiopronin and doesn't form stones at all on tiopronin, but she's had 4 children and had to stop the tiopronin on all occasions, and she's formed bilateral staghorn stones on each occasion. And you can count the number of scars she's got in her back from all of these different interventions that she's required over the years. And the picture on the right is of a JJ stent sitting in the bladder. And these patients are at risk of encrusting their stents very quickly. And this was a picture taken at 13 days. And you can start to see early incrustation forming on this stent within 2 weeks. And that's quite scary, given that some patients are made to wait for weeks or even months with a stent in for their surgery. And so this really must be prioritized for this patient group. So the principles of surgical approach, well, lithotripsy can be used in select patients, and that is what we do, because although stones are thought to be hard, some of them are soft. And so if patients have had it before and it works, then it is worth trying again. And if patients do require treatment, we should offer early treatment, because if they're unlikely to pass their stone, because these patients are going to get repeated insults to their kidneys over the years, and you want to try and avoid this causing long-term renal damage. Like any stone, and certainly like any metabolic stone, we should aim to render the patient as stone-free as possible. And there's evidence that if you are truly stone-free, then you've got more chance of staying that way. We do believe there is an extended indication for ureteroscopy because of the repeated insults and trying to avoid percutaneous surgery if possible. And actually, these patients often have quite dilated ureters and making passage of the ureteroscope easier and requiring less stenting. So we often may take on slightly larger stones than you would normally think you would. And again, that message that stents can encrust very quickly. Over the last few years, a combination at the same time of both PCNL, so percutaneous surgery, and flexible ureteroscopy, known as ECIRS, or endoscopic combined intrarenal surgery, has become increasingly popular. And this is quite helpful in this patient group where you want to try and render them stone-free in one sitting. So we increasingly do that for patients with complex stone burdens. And this schematic just shows a timeline of what we're aiming to achieve. And this was a recent patient that we had in the last year. She emailed us on a Wednesday, so time 0 there, because she was in pain and problems. We saw her in clinic 2 days later. She had a CT scan from that clinic on the day. She's got an upper ureteric stone here obstructing. She's starting to feel unwell and feverish. We admitted her and she got stented, in fact, that afternoon. She was appropriately discharged with antibiotics to treat the infection, and we readmitted her 10 days later, so 12 days after the initial email. And this is one of those combined procedures. So you can see a ureteroscope here and the PCNL sheath to clear the kidney of stones in one sitting. And then just to show some of this, I'll just start this video running. So this is a fairly large stone. On CT scan, it measures 16 millimeters, and often I think people will be thinking, over 15 millimeters, would that be better off with a mini PCNL? But actually, when you look at the video, it's in quite a capacious system there, isn't it? And the images you get now with some of these digital scopes are amazing. And so we decided to take this on with ureteroscopy. And in the interest of time, I may not play the whole video through here. But what we can see here is the Holmium laser breaking and dusting the stone. And what we're trying to do is to paint rather than just sort of drill into it and create large fragments, what we're trying to do is chip away at the edges, as you can see there, and paint on it to try and dust and just create tiny fragments until it becomes too small to keep doing that. And then if you see here, now this is sort of more towards the end of the procedure, we've now been able to push the fragments back. So this is what is left. And so this is now using a technique called popcorning, where you're trying to laser the fragments and they actually collide with each other and fragment, and then just inspecting the calyces to make sure that they're as small as possible. And she was stone-free on post-operative imaging at 3 months. This is a different patient. This isn't a video. This was one who we thought we could take on with ureteroscopy, but actually, based on this CT scan, but actually when it came to the surgery, the stone was much larger here. You can see it outlining here with the retrograde picture than we expected. And so actually, he was better treated with a mini PCNL. So that's what this is here. So this is just a standard PCNL where we're able to break up and extract the stone through a fairly small tract. This is a 16 French tract, and here are all stone fragments. This patient has got a very complex stone. This is the CT scan. There was an upper ureteric stone on the right and this staghorn stone on the left. And it's quite useful to get 3D reconstructions of these just to plan the surgery and look at the complexity of what we're going to do. And so we treated this patient with a combined procedure as well. And this just shows some of the techniques now that we can do with this. And so these images look so nice because we're looking through the nephroscope at this video. from one surgeon while the other surgeon is lasering the stone. And we're using a very different technique here to break the stone, because we don't want this into dust and tiny pieces. We just want large fragments that we can extract. So we're almost sawing across that into large chunks to enable them to be extracted. And then you're able to pull the fragments out using a basket and then extract them through the nephroscope, so that you know that you've got all the fragments clear at the end. And then this just shows the basket coming out with a fragment, and then this technique is called pass the parcel, where we can then pass this into the nephroscope sheath and then release it and extract that stone. I'll hand back to Kate to finish the presentation.
So there haven't been any new drugs that have come to market recently, but there are quite a few new therapies in development. So these range from drugs that we already have, such as alkalinization, to thiols, a new thiol, and then repurposing existing drugs such as tolvaptan, which causes a diuresis and is currently used for adult polycystic kidney disease, but there have been animal and human studies in cystinuria. There are two herbal remedies. One is cysteine, which has not been shown to make any difference in stone formation, and the other one is ALA, or alpha lipoic acid, which I'll tell you more about in a moment. There's an interesting cysteine analog, which was discovered during experiments with atomic microscopy and then used in a mouse model where it was shown to reduce stone formation in the mouse. The problem with bringing this drug to market is that at present it's not suitable in humans, and so those studies are still ongoing. What will be interesting over the next 5 to 10 years, given the previous discussion about genetics, is whether we can find any gene therapies for the mutations that have been identified. So this is a slide on alpha lipoic acid. There had been some interesting possibilities in the clinical mouse model, showing significant reduction in stone growth, and also a case report within children about it increasing cysteine solubility. So on the basis of this, there was a double-blind randomized trial of ALA versus placebo, and in the graph on the right you can see ALA in orange and placebo in blue. The overall number of stone events was not significantly different between the two groups, but there was a suggestion of reduced stone burden and reduced stone growth, as you can see from the orange lines showing negative stone growth during the course of the study. So it is available easily because you can buy it over the counter, and it is therefore cheap and does show some promise, but at the moment there's a limited amount of evidence for it. So these are two guidelines. Matthew's already mentioned one of them, which was the Cystinuria clinical practice recommendation, published in Kidney International, and was a collaborative piece of work with colleagues from ERKNet and ourselves from eUROGEN. There's also another publication we've been involved with, American colleagues, a consensus statement, which again tries to pull together some recommendations for these patients, given that it's a rare disease. So it's not well covered in standard textbooks or within existing stone guidelines. This is an infographic from the Kidney International publication, which just gives an overview of the approach to cystinuria, much of which we've been discussing during the course of this webinar. One area that we've concentrated a lot on, given that cystinuria is a rare disease, is the patient support for a chronic condition which may start very early in their life. Because it's a rare disease, we often find these patients and families are quite lonely. There's no peer-to-peer support because they probably never met another patient with the condition, or at least not until they come to our clinic and sit next to each other. Doctors often don't know as much as the patient and may be reluctant to listen to the patient, and that can be very frustrating. There's definitely a challenge of transitioning from teens to adulthood. Much of the management we talked about is around fluids and diet, sort of self-care, and while patients are children, obviously their parents are very actively involved with that. But then as they become teenagers and leave home and become young adults, then they can not be as good at those things as their parents were, and that can lead to problems. So we support them through that particularly difficult time. It does have an issue and an impact on employment. These patients have acute renal colic, which means unexpected absence from work. They also need admissions for elective procedures, and they have to come for regular clinic monitoring. And this we find can have quite a significant impact on their employment and livelihood. One area that patients are worried about is pregnancy and passing this condition on to their children, particularly if they've had severe cystinuria symptoms themselves. And in the clinic, that's something that we support patients before they've had children, during the pregnancy, and then afterwards when they may want to have their children tested to know whether or not they've passed on the gene. There has historically been quite a lack of patient information and not much clear guidance on websites, and that's something we've addressed, as I'll show you in a minute. And then we found that through our studies and those of others that they have a worse health-related quality of life, which is an important thing to acknowledge and discuss. So we aim to empower them to help themselves with diet, medication and monitoring, as we've shown, but also act as advocacy and patient education for this group. So we've had within the UK patient information days with several other smaller centres who collaborate on this work, and we meet together in different locations in the UK to educate the patients, but really for them to educate each other, meet other patients and share stories. And this has been particularly valuable for parents of children, because patients can come with their families and their support network. We have 2 cookbooks that you can see here, which are freely available on the website to download. And these give guidance of the type of ingredients that are helpful if you have cystinuria, and also recipes to inspire patients. We're delighted that a group in Romania found these cookbooks and contacted us asking if they could use them. And not only did they translate them, but they rephotographed all of the recipes and published their own cookbook, which is brilliant. In terms of patient forums, there are Facebook groups, one in the UK and International Cystinuria Foundation, which is an American group. And we've set up Cystinuria Support, which is on a platform called Health Unlocked, which is run by patients for patients. There's also a website from International Cystinuria Foundation, but we've established one called Cystinuria UK, which gives information to the patients, much of which has been summarised in this webinar. Although it's called Cystinuria UK, you can see from this picture that it's been accessed not just in the UK, but from all over the world, and therefore has provided a useful resource for patients and their families. We discussed briefly about pregnancy and showed you a picture of one of our patients that's had surgery after each pregnancy. And about a quarter of our patients think cystinuria is a barrier to pregnancy. Sadly, some of them have been told in the past to never have children. A third had to cease medications, and this obviously comes with risk of stone formation. A third passed stones during their pregnancy, which they found very difficult. And about half felt they formed stones that needed treating. As many as 90% of our patients were worried about their children having cystinuria, and it's a common discussion that we have with them. So we discuss, if they're planning a family, we discuss in advance and plan their medications. We increase the number of follow-ups they have. We reassure them about how they will be followed up, and if worst case scenario, they needed surgery within pregnancy, how that would happen. And we make sure they have regular ultrasounds. So the take-home messages are that this is a challenging condition to treat. It's a rare disease, and so a lot of the time the doctors seeing these patients for the first time may not know much about the disease. We recommend diet and fluid advice for all patients, and you can see how successful that can be, along with alkalization in the patient that had a staghorn at first presentation and no further stones since. If these are not enough, then we do add in a chelating agent, but you have to be vigilant with the monitoring because of the side effect profile. We've set up a service to make sure there's easy access for patients, and this is important both to prevent stone formation and protect renal function, but also to minimize the impact on their life, particularly as they're often of working age or with young families. We offer regular follow-up with ultrasound to try and avoid the lifelong exposure to radiation. It's very important that we continue as a community to engage with these patients and be advocates for them because of their rare disease. And we try and personalise the surgical approach as much as possible, as you heard. We try and get these patients stone-free where possible, treat them quickly, and minimise the stent dwell time. Thank you very much.
Right. Thank you so much for being here. As the attendees might have noticed, the presentation was pre-recorded, but our presenters are here to answer your questions. So feel free to type in your questions in the questions field. Like I mentioned at the beginning of this webinar, you can find the question box somewhere, I think, below your screen. For me, it's at the below of my screen. It has a Q&A with a question mark icon on it, and that's where you can type in your questions. I could already see that we have one. So if you could read that out loud and then discuss it, that would be great. Thank you.
Yeah, sure. Thank you. Good evening, everybody. Yes, we did pre-record that earlier. We thought that was easier and safer to make sure there was no IT glitches. So yes, thanks for the first question. Before I answer that, I thought what we might talk about in a second, one thing that we mentioned in the webinar was about tiopronin and supply and shortages. We have terrible problems in the UK with this. Be quite interesting if anyone wanted to either ask questions about that or put any comments in the Q&A box about issues to do with cost, supply and availability around Europe. So I'll just mention that now just before we answer these questions, just to give people a chance to think while they're typing their questions. So the question from Joseph is two practical questions. How would you titrate potassium citrate in a recurrent stone former with a urine pH of 6.3 despite a 3.2 litre urine output, specify pH goal and monitoring cadence? So, okay.
Yeah, thank you. Yeah, good question. And one obviously that we encounter a lot. So the first thing that we do before we start people on potassium citrate is get them to do a pH diary, as we mentioned in the talk. And we get them to test their urine different times of day, different days, because depending on obviously on their diet and activity, their pH will change. And we ask them to do that for roughly a week. The format of how they do it is obviously dependent on them, as you saw from the examples we gave you. And then depending on that, we start them on potassium citrate, because sort of conventionally in the textbooks, it'll say 10 mils 3 times a day as a sort of standard, but actually not everybody needs that full dose of potassium citrate. So we do very much tailor it according to people's urine pH. With this patient who's got quite a low pH, we would be aiming for sort of 7, 7.5. We don't want patients to go too high because they get calcium phosphate stones, potentially. It's not that common, but we have seen a few patients that's happened to, so we need to be careful. And the time that can happen is if patients start on potassium citrate, but then also start addressing the dietary side of things. So, for example, reducing their animal protein, processed food, etc. That can naturally change the pH of the urine. So actually, if someone's made significant dietary changes, it's probably worth getting them to do another pH diary, because it may be that they can stop the potassium citrate. And that's happened in a few of our patients. So I would make sure they're actually taking the medication, because potassium citrate liquid tastes quite disgusting. So a lot of patients don't actually take it. So if the pH is low, obviously you just need to make sure that they are actually taking it. And if they're not, there are other preparations. So either something called efficitrate, which is a fizzy tablet, or rather it fizzes when you drop it into water. So it tastes a bit nicer and it's a bit more convenient to carry around rather than a bottle of liquid. And then there's another one called EUROGEN, which is just a small tablet that you swallow, which again is more convenient. For us in the UK, that's much more expensive for some reason, and it's an off-label prescription, but obviously that'll vary depending which country you're in. So I think those are the things I would address. We don't tend to use sodium bicarbonate because of the raised sodium levels. We use potassium citrate where at all possible.
Yeah, very comprehensive. I'm not sure I have much to add to that. Just to mention, we did have a patient once who had been well controlled for years, actually, and he became diabetic. And we saw him back and he told us he'd been diabetic and he started forming stones because his urine was now much more acidic. And so actually making sure all those things like diabetic control are optimized as well is really important. So I'll move on to the second question then. So a patient is on tiopronin, in his example, 900 milligrams a day, with a supersaturation cysteine capacity of 0.9 or a negative cysteine capacity. What would you adjust first? Dose of the tiopronin, alkalization, or dietary sodium, or would you do them all at once?
Yeah, another great question, Joseph. Thank you very much. So I think for us, as you probably get the sense from the answer to the previous question and from the presentation, we would have focused on the dietary sodium and alkalization first before putting the patient on tiopronin. But again, as I just said, it's still worth going back to that because patients, they start doing something enthusiastically and then for a variety of reasons may not be doing that as much. So it'd be worth just going back and checking their dietary intake of sodium, and also for the reasons I just said, that they are managing to take the alkalization therapy rather than just assuming that they are. If those two things are optimized, then we would increase the dose of tiopronin. And I'm just going to bounce a question to Matt, because otherwise it's just me doing all the chat. How would we know what dose to put them on that?
So I suppose the first point I was just thinking in all of this, I would also want to know about their stone formation. So I don't think it is just the parameters, is it? It's actually, are they making any stones, or are they having any problems? And actually, if that's what the figures show, but they haven't been having any problems, then I wouldn't actually change their dose, and I would make sure the other things are optimized. So then it does depend on what. So then, if they are having problems, then I think I'd adjust it anyway. And I think you then do want to make sure that you probably would do everything, but you do need to make sure, as Kay says, that those other things are corrected for, and it's not just about tiopronin. What do I do here? I mean, you go up incrementally, don't you? So we've historically gone up from sort of 750 to then maybe 1,000 milligrams in split dose, and you probably go up to 1,500 milligrams a day, again in divided doses as the next dose point, if that's what you were doing. Because of the issues we were sort of talking about, we've actually had 100 milligram tablets rather than 250 for some time now as a supply. And so therefore those are slightly different how you adjust it. And also talk to the patient about how they're splitting the dose, and are they taking that 3 times a day? Is it 4 times a day? Because you do want to try and make sure it's spread out throughout the day.
Yeah, and then just going back to the basics of making sure they're drinking enough fluid, because some patients are brilliant at that and some really struggle. And again, through dietary advice, they can take foods or have liquids in different forms, such as soup or whatever. But it's just worth always making sure you go back to the basics of fluids. And then the other thing, I suppose, with the dosing of the tiopronin, as well as Matt's point about whether they're actually forming stones, but it's also just checking they've got normal renal function, because you have to be careful. If they've got poor renal function, then you are limited with your dose of tiopronin. So again, it would depend on that as well. And we've got a couple of other comments. Thank you very much. We're just having a quick look.
Yeah, so thanks, Sally. Thanks for a great presentation. It's been a pleasure. We enjoy talking about cystinuria, as you can probably tell. And then a comment, I think, from said Aberdeen,
We, as well as our renal physicians, have struggled to get hold of tiopronin in the West Midlands. Are you happy to receive referrals for the difficult to control cysternurics, and who do you need Thiola? So that's a very topical comment and question, actually, and I suppose that's a little bit what we're alluding to in what I said earlier about tiopronin, is that this has been challenging in the UK. This is an unlicensed product in the UK. That won't be the case in other parts of the world, so therefore it is more difficult to get hold of. And prescribing restrictions has meant that this is now pushed into hospital prescribing only, and this isn't prescribed in primary care. That's the first thing. Then the second thing has been supply shortages of supply, which has been quite common, and that it's been unable to source. And thirdly, and coupled with that, and probably some of the reason behind it, has been price gouging, which has occurred I think just over 5 years ago. I can't remember exactly when it happened, when the company that used to make it were bought out by a different company who I think had seen that it was an old medication, but recognized an opportunity to and increased the price by 1,000% overnight with some modifications that they then made. They made a modified release version and things and tried and justified it on that basis. And so I think that is maybe why you're having trouble getting hold of it, is actually that people aren't, it's the cost of it that is prohibitive when it all is passed into the hospital, in the UK system anyway, passed into the hospital system. And so we obviously face those challenges as well, and we're going through a review actually of our patients at the moment because of this, just to make sure that we're not overusing tiopronin. So in the UK anyway, because of these challenges, we have been preferentially using penicillamine where possible. So if patients haven't tried either medication before, we preferentially try penicillamine. So I would definitely recommend you do that first. If they're on tiopronin and never tried penicillamine, we've been switching those patients to see if they can tolerate that, and if they do, then obviously that's good from the supply and cost perspective. But then, of course, if you try those things and you need the medication, then there is no choice. So yes, we've had a number of referrals from around the country for cystinuria in general, but also with medication issues. So I think it's work in progress really as to what carries on in this space. And we've actually been doing quite a lot of work as well, and maybe Kay, you want to talk about that over the years with other colleagues from the Royal Free and Newcastle, and NHS England, so UK specific, in terms of trying to look at the supply issues with tiopronin.
Yeah, I think that's where the sort of essence of the reason we're on this meeting, the rare disease sort of collaboration. This is obviously across Europe, and we've got smaller version within the UK. That's where it's really important, and using the patients as the advocates to help with this. So certainly with the off-license drugs in our hospital, we got patients to write in as a sort of support of how important these drugs were to them. So I think that bringing together people who are interested in treating patients with rare diseases helps with that, helps with lobbying, and making people aware of how important these medications are, because on the face of it, there's not many people when you're comparing it to, say, cancer drugs. And so I think that's a kind of important aspect, and we've had many attempts actually at lobbying on behalf of our patients. And it's something you need to keep doing every few years. It seems someone comes along and tries to streamline things. So I suspect, obviously we're talking from a UK perspective, but I suspect that also happens in other countries to a certain extent as well with any rare disease.
Yeah, and the American model will be different. Those with insurance where they pay for drugs, they'll be okay, won't they? But of course, there's a lot of people in America without that, and then they suffer and can't get hold of it. And we're just joining a study actually with America as well, looking at some of the financial toxicity and issues associated with that in having conditions like cystinuria. And it'll be very interesting looking at the two countries, because it'll be similar and also very different in terms of, our drugs are free in the NHS, they're not in America. But people, do struggle, and we talked in the webinar about holding down jobs and money and things like that. And it'll be very interesting to see what comes out of that.
Right. I'm not sure there's any other questions at the moment. It's nice to see you, Sally, virtually. Oh no, we have got another one, sorry.
So
Well done.
maybe a final question then. We haven't pre-read this one. Thank you for a great presentation. What is the stone size threshold below which you do not intervene? And do you sometimes decide to leave certain stones in place? Good surgical question.
Yeah, good. That is a good question. So to answer the second bit first, yes, we do. We try to get people stone free, but if there's an area that's inaccessible, or maybe the patient, you've cleared them, but then they reform quite quickly, and those we decide to leave in place and observe for a while. That assumes obviously they're in a part of the kidney that's not going to cause any obstruction. And then in terms of stone size threshold, again, that's quite personal to different patients, because some of our patients pass really quite big stones that, you know, they bring them into the clinic and you can't quite believe they've passed a stone that big. And you would never normally leave a stone of that size in somebody, but they and we know that they can pass stones of a certain size. So even a centimetre, some of our patients have passed a stone, whereas with a non-cysteine stone former, you know, patients struggle sometimes to pass a stone of 3 or 4 millimetres. We've observed, although there's no science behind it, but it's something that quite a few urologists have observed, that cysteinuric patients seem to have wider ureters. And we don't know whether that's because they've passed more stones or have more interventions, or whether it's related to the disease in some way, but it does mean that they can pass stones more easily generally. So I don't think there's a specific size threshold. It's more personalized really to where the stone is, which would be the same for any stone former, but importantly the kind of history of what the patient's passed before. If they've only got one kidney, then we're obviously always much more keen to intervene, because the consequence of them getting a stone stuck is much greater, although equally the consequence of operating on a single kidney is also greater. So we have to balance those two things.
Yeah, I was about to mention the solitary kidney thing obviously is really important, and that's so common as well in patients with cystinuria. I mean, just thinking back to some recent patients, you know, we have patients with a 4 millimeter stone in a single kidney who want that treated and want it removed because they know that they've struggled before and they can't live with having that stone in their kidney. And yet we saw someone in our last clinic who had a 7 millimeter stone which had grown slightly in the lower pole of his solitary kidney, and he was like, oh, shrugged his shoulders and go, well, that's easy, I'll be able to pass that if it moves. So I'll see you in a year then. You're like, oh, okay, that sounds quite bold. So I think it does vary. It is like any stone consultation, I suppose, in terms of how you treat patients. It's going to be very individualized. And it looks like we've got a final question as well, if we've got about a couple of minutes to run on. So thank you, Pankaj, great talk. How do you choose cysteine patients for shockwave lithotripsy?
Yeah.
Shall I take that one? So again, I think this is a very individualized decision. Patients will often have had lithotripsy before. If they've failed lithotripsy previously, we won't try that again in general. If they've had successful lithotripsy before, then that's pretty obvious, isn't it, that you may well offer them that again. And then of course there's a cohort of patients who've never had any of those, and then I guess we discuss that like you do in any consultation, offering them the range of treatments that are available. Probably have a slightly smaller threshold for treating cysteine stones than you do normally. I mean, you know, the guidelines for any stones say treating stones up to 2 centimeters with shockwave in the AU guidelines. I mean, I would say we would very rarely go as big as that anyway for any stone former, and probably in my own practice 12 millimeters maybe the maximum for in general for stone formers. You know, lithotripsy, cystinuria may be slightly smaller than that, so you're going to take on maybe slightly easier stones than you would do normally in terms of size and volume. But we do have some patients who really get on well with it, and it does work. So it is you can't tell from CT what is a soft stone or a hard stone, but stones that have formed relatively recently often are, and I think anecdotally are softer, and you find that when you laser them. Stones that have been there for a long time are often harder, so maybe that can also be a guide. I don't know if you have anything to add to that decision making.
Yeah, no, I think that's right, and maybe the position of the stone as well might make you think that you prefer to do lithotripsy. But yeah, no, I would agree. And it is similar things to be said in the talk. for uretroscopy versus PCNL. We actually would do uretroscopy for bigger stones than we would for non-cystine stone formers, because we're trying to limit the number of PCNLs they have, because there is inevitably a little bit of renal damage with each PCNL. So there's no absolute number you can do, but it makes common sense not to do too many. And each PCNL you do is more difficult because you've got scar tissue from the previous one. So we will treat up to 2 centimeters uretroscopically in these patients. And again, with the wide ureters they have, that's usually easier from a technical point of view, and also for them passing the bits afterwards. But what we're really vigilant about is not leaving them with stents in for a long time, so less than 2 weeks.
Great.
Great. Thank you so much. I think that were all the questions. Thank you for presenting your presentations and for doing such an elaborate discussion section. I think it was really helpful. So thank you so much for being here, and thank you for the attendees who attended this webinar. I have my final typical announcements to make, that the webinar has been recorded. So I will be sending the link for the YouTube recording tomorrow to everyone who registered. And for the live attendees, like Michelle mentioned at the very beginning of the webinar, we will be sending a post-webinar survey. So if you would fill that in, we can continuously improve our sessions, but you will also receive an EACME certificate from me within 2 weeks. So thank you so much for being here. And I wish you all a very nice evening.
Thank you very much. Thanks for inviting us. And thanks for the great questions.